posted. This particular PowerPoint is not, but I will send it to Dr. Hall, as soon as class is over, that way we can have access to it. I will be recording, but nobody, you guys won't be in it, it'll just be me and the three in the PowerPoint. I mean, in the recording. After, class today, or after I finish the lecture, I'm not sure if I'll get through all of it today, but there will be, Dr. Hall will post on the Canvas evaluation tool. So the first one will be last name is A through E, and then, for the first link, and then if your last name is F through Z, there'll be another link to complete the evaluation. Okay? Get started, so we're gonna be covering the postpartum, and that's chapter 17? Yes. Yeah. Are we looking at all reading? Am I hearing it with them? But all right. Let's get started. So yeah, chapter 17 and chapter 23. All right, so our objectives today will be to describe the anticipated physiological and psychosocial changes in the patient in the immediate postpartum period. We will identify pertinent postpartum nursing assessments and care considerations. Identify variations in postpartum care required by patients that have given birth and compare with those with cesarean birth. Discuss the important aspects of discharge instructions. So we got some key terms here. I won't spend too much time on it because it's directly in your textbook. We've got after pain, which is uncomfortable cramping of the uterus in the postpartum period. Approximation is approximately a woman edges to each other. And we got the body uterus, which is the conditioning uterus and soft palpation of postpartum. And we got aggressive, envious, involution, which is the process by which the uterus shrinks postpartum. You got lochia, which is the vaginal discharge, composed of mucus, blood, and tissue. And then you've got prolactin, which is a hormone of lactation and expresses ovulation. And then you've got rugae, that's the folds within the vagina that allow the stretch through childbirth, and that return postpartum. And then subinvolution, which should be that measured is a condition involving the failure of the uterus to shrink postpartum. And then you got a thrombus. All right, so the way your textbook has it, it's separated in systems. When I'm talking about the physiological changes in the postpartum period, you've got the uterus, and then assessing the fundus postpartum physiological changes will be the evolution that we just briefly talked about, and a combination of hypertrophy and hyperplasia causes the uterus to enlarge during pregnancy. Contraction of the uterus aids in the evolution process, which is the shrinking of the uterus. If the uterus does not contract sufficiently, then uterine attenuation, and that can cause hemorrhage from the site of the placenta. Postpartum bleeding is primarily controlled by the compression of the constricted uterus, which would be like your contractions. The video here. And this is also, I don't know if you guys have the online access to the textbook, but this is where this is located.
Hi, I'm Molly, your nurse. Congratulations on your baby.
Thank you.
I know the nurses in labor and delivery checked your fundus and lochia every 15 minutes for the first hour after birth. And then they helped you to the bathroom and got you cleaned up. Here in postpartum, I'll be checking your uterus and bleeding every 4 hours.
Okay.
Now, have you gone to the bathroom recently?
Right before you came in.
Good. That will help with a more accurate assessment.
After sanitizing your hands, put on gloves and identify the patient.
Can you tell me your name and date of birth?
Sure. Sherry Cantanovo, November 22nd, 1988.
That all matches. Now I'm going to lower the head of your bed.
Lower the head of the bed and place the woman in a supine position so you can get an accurate assessment of the uterus. The number and timing of these subsequent assessments depend on the woman's clinical situation and the institutional policy.
May I lift your gown so I can gently press just above your belly button or umbilicus to check your uterus?
Okay.
Okay. Let me know if there's any acute pain.
Place your non-dominant hand directly above the woman's symphysis pubis while the dominant hand gently palpates the uterus. This hand placement is important because it supports the uterus and helps prevent uterine inversion. If you do not feel the uterus, move your dominant hand closer to the umbilicus and repeat the procedure. The uterine position is often documented as the number of centimeters above the umbilicus, at the level of the umbilicus, or the number of centimeters below the umbilicus. If the bladder is full, the uterus will be higher than expected and deviated to the side, not midline. The uterus will not be able to clamp down effectively until the patient's bladder is emptied.
Here's the fundus, which is the top of your uterus. It's 1 centimeter below your umbilicus. It feels like a firm, round mass, which is normal. Would you like to feel it?
Yes, I would.
This is what a uterus should feel like after delivery. It's nice and firm to decrease bleeding. It's also midline where we expect it.
That's good.
Each day after delivery, the uterus will decrease about 1 centimeter. In about 10 days or so after the birth, you won't be able to feel it anymore.
The process of the uterus returning to its pre-pregnancy size and shape is called involution. A normal postpartum fundus feels firm, midline, and near the umbilicus. If the uterus feels soft or boggy, it is not well contracted, which increases the risk of a postpartum hemorrhage. For a boggy fundus, the nurse should gently massage it by applying circular motions with the dominant hand until the uterus feels firm.
I'm going to look at your bleeding. When was the last time you changed your pad?
I changed it when I went to the bathroom.
Good. We evaluate your bleeding, called lochia, by the amount of drainage on your pad. The vaginal discharge after childbirth usually lasts between 2 and 6 weeks.
That's good to know.
You have about 3 inches of lochia on the pad. This is a small amount and it's normal. Heavy bleeding is when a pad is saturated within an hour. I'd like you to let me know if you experience heavy bleeding.
I will.
Now I'm going to help roll you onto your side and have you lift your top leg up so I can make sure the lochia is not pooling underneath you and so I can look at your perineum.
By turning the woman on her side, the nurse can evaluate the pad and check that the lochia is not pooling underneath the woman's buttocks. If applicable, the nurse would also be able to assess perineal lacerations or episiotomies from this position to determine if the incision is well approximated or if there are any signs of infection.
I don't see any excess bleeding or any signs of infection. You may notice some clots when you change your pad. If these clots are small, they can be normal, but please let me know if you notice any clots larger than a plum or if your bleeding gets heavy so I can take a look and evaluate your uterus and lochia.
Okay. Could that be a problem?
It can be. We'd like to make sure your uterus stays firm and your lochia is within normal limits. If it isn't, then we would do fundal massage to help your uterus become firm, and we would call your provider to let them know what was going on.
Thanks for letting me know.
You're welcome. Right now, everything looks good. To help prevent infection, you should wash your hands before and after using the bathroom. Also, you should change your pad every time you go to the bathroom, and you should use pads, not tampons.
I can do that.
You can also prevent infection by spraying warm water from a peri bottle over your perineum every time you go to the bathroom. Then pat dry with toilet paper, always wiping front to back. This will help everything stay clean. It's helpful to keep an ice pack on your perineum for the first 24 hours after birth to prevent swelling. Can I get you a fresh ice pack now?
Yes, please. It felt really good before.
As always, document procedures and how the patient tolerated them. Also document assessments, findings, and patient education that was provided. Remember that a clear, concise record is one of the most important aids to patient care.
Alright, and some of the things they brought up in that video we'll cover throughout the lecture. Get back our presentation. Alright, so as I mentioned earlier, sub-evolution, excuse me. Okay, sub-evolution is the failure of the uterus to shrink at the expected rate. The uterus is at the umbilicus 24 hours after delivery, exactly where it was around 20 weeks of gestation, which is about right here. After the first 24 hours, the uterus should come down from the umbilicus about 1 to 2 centimeters. So we've got these lines here are kind of basically marking where the 1 centimeter should be. Alright, you got 2 weeks, by 2 weeks postpartum, the uterus should again be the size of the pelvic, pre-pregnancy pelvic organ. By 6 weeks, it should be inflated completely, and then postpartum period, the uterus weighs about 1,000 grams, and then by 6 weeks postpartum, it should be down to 70 grams. Alright, during that immediate postpartum period, they typically administer oxytocin, and it's usually given IV, but sometimes it can be given intramuscularly. Breastfeeding also stimulates the release of oxytocin and helps with uterine contractions as well. Alright, the after pains, they also aid in uterine contraction and vascular constriction at the placental site, and that's what you want to prevent postpartum hemorrhage. If the bladder is distended, that can worsen after pains, and it also can increase the risk for uterine abscess. And some things you can do for interventions would be to apply heat to the abdomen, and also analgesia as they're ordered by the provider. Alright. The healing of the placental site is very important. Scarring can cause issues with future pregnancies. It can also cause issues with the implantation of future pregnancies. So to prevent that scarring, the body will slough off that necrotic decidua. This process of regeneration replacement of the decidua with the endometrium is completed by the end of the 6-week postpartum period. So you've got lochia, and that's the discharge from the uterus. It's composed of sloughing of the decidua and other debris. It lasts for about 4 to 8 weeks, and it should change in color and consistency over time. It starts from your textbook. It just kind of goes through type of lochia and the appearance, composition, how long it should last, and some abnormalities that you would take note of. With lochia rubra, with the patient who had a cesarean section, it may typically be a scant amount of lochia, as opposed to a vaginal delivery where it's going to be obviously more. Perfuse or persistent bleeding from the perineum is concerned for hemorrhage or retained placenta or retained fetal membranes. And after pains from breastfeeding and ambulation can also increase the lochia throughput. And common for lochia rubra to reappear a week or 2 after birth. So sometimes people will stop bleeding a few days, and then about a week or 2 later they'll start to see some more bleeding. Sometimes they're concerned, so just let them know that that's a normal finding. Just keep an eye on their clots and the amount of bleeding. Just like I said to you, so lochia rubra that returns and persists for more than a few hours is concerned for secondary postpartum hemorrhage. Lochia should be it's typically a slow trickle and dark in color. With after pains, it may be a brief gush, or when you do a funnel shape uterine massage, you might see a little bit of a gush come out. If they assume an upright position after doing lying upward for a long amount of time, you may see a gush as well then. Blood that appears to spurt or pump or persistently bright red in a patient with a contracted uterus is not likely to be lochia, and it will be pretty apparent when you see it. It will just be gushing out, and that's how you know it's just not your normal lochia. This type of bleeding is suspicious for lacerations, like a cervical laceration that would be more, obviously internal, vaginal lacerations, and those are usually identified shortly after birth. And it needs to be reported to the provider because they may have to do some surgical interventions for that. This chart here is also in your textbook. If you've already been on mother baby, you're kind of familiar with this mnemonic. It's very helpful when you're doing a postpartum assessment, so I would take note of that. So when you're providing nursing care in the postpartum care, you want to make sure you always wear gloves because you may encounter, probably will encounter body fluids. You always take note of the lochia, the tone, and the location of the uterus and evolution, which means you want to know where the fundus is in proximity to the umbilicus. And so your highest risk for postpartum hemorrhage is within that first hour after delivery. That's why your frequency and assessments is higher after delivery. Usually about every 15 minutes they'll be doing a fungal check, just to check for bleeding, making sure the uterus is not, the fundus is not getting bigger, because that would indicate there's some blood or some irritation in the uterus. Let's see. They usually do every 15 minutes for about an hour, and every 30 minutes, and every hour for 4 hours. And per protocol, it's depending on where you are, or per policy. Postpartum hemorrhage in the first 24 hours after birth would be primary postpartum hemorrhage, and then it's between 24 hours and 12 weeks after, and secondary. So, just like any other patient, you would always inform them of what you're going to do before you do it. Before you touch a patient, you're just going to talk about what you're going to be doing, especially the first part of the assessment, because it's very personal, I would say. The nurse should always ask about when their last void was, whether they changed their pad, whether they had breastfed, experienced any after pains, or if they recently came pregnant. If they can't remember, you want to make sure they go to the bathroom. A full bladder could cause the uterine apnea and the hemorrhage that we talked about. A uterus that is not midline when palpated is often displaced to one side of the other by full bladder. Alright, to assess the progress of the uterine evolution, you want to make sure you stabilize the lower uterus right there, in the area. Provide that support before you put that pressure or palpate and find the fundus, because you don't want to cause uterine inversion, which is a condition when the fundus of the uterus prolapses first or even through the cervix. It's extremely rare, but it's still important to provide this support every time you palpate. When feeling for the fundus, you want to make sure you provide that support, and then you want to start at the umbilicus and move down. And palpate deeply but gently, because obviously it's tender, because they just delivered. Sometimes if they are larger in size, you may have to palpate even more deep to feel that fundus. Make sure they are laying flat, because it's not an appropriate assessment to have them sitting up during that. Your expected findings for when you're palpating, when you're doing the fundal exam, would be you want it to be midline, you want it to be third, and you want it to be in the limited degree anticipated by the time of birth. So what that means is, if you're the postpartum nurse and they bring the patient down and said, I've got her one below umbilicus, you want to make sure you're either there or going lower than that. You don't want to be one above, because then that's a concern for hemorrhage and other things, like retained placenta. A uterus that is not firm is body, that indicates uterine atony and an increased risk for hemorrhage. Nurse should, and if you find that the uterus is body, you want to make sure you just massage it, provide that support while you're massaging with the palm of your hand, and the OB provider will probably order Pitocin, but they may also order other things like Cytotec Yes.
I was just gonna ask, how long are you massaging the back uterus for? Or is it just
So
like
there's not really a standard of how long you massage. You typically feel it firm up.
Okay.
Once you do that massaging, if you don't feel it firming up after a few minutes, just keep going, call for help, or ask somebody to notify the provider. So yeah, we're talking about they may infuse oxytocin, you may get things like side effects, and some other medications that we'll talk about further on. If the uterus is firm and the lochia is heavy, you just want to make sure you reassess in about 15 minutes, because sometimes you will find that the uterus is firm, it's midline, it's where it's supposed to be, but then you see like this gush of blood. If it's just if it's just there, I'll get you this in a second. But just come back in 15 minutes and reassess. If you still see that heavy bleeding, then you may talk to the provider. All right, because it could be a laceration or something like that if they had a repair. Did you have a question?
When you're documenting that, how do you document, like, what are the language for that?
For the fungal assessment?
No, for the lochia. So are
The
you
lochia.
like saying like how saturated the pad is as far as like?
So you would document, the amount would be, so you say scant, is it moderate?
Moderate.
Scant, moderate, and heavy. And then you would, document the color. So whether it's dark, and in any epic, there's always the prompts that are over on the right side of the flow sheet. So you want to document amount, color, and, that's it. Oh, odor, if you've had any odor or anything like that. Can you answer your question? Okay. Does somebody else have one? Yes.
So you said, after you do the massage, if you see a gush of blood, should we be checking the lochia before and after, or you do it and then you notice the pad is saturated? Like, how do you know that there's a gush of blood?
You would, so as you're doing the fungal check, you always want to explain to the patient to just kind of relax your legs so you can see while you're doing the fungal check. So you should be able to examine that while you're doing the fungal check. Okay, so we talked about that, just knowing where the fundus is in relation to the ending of the abdomen and umbilicus. Alright, so we talked about if the uterus is deviated to the midline, just make sure they void before the assessment. And we talked about the way to document. So the position of the uterine fundus in relation to the umbilicus is recorded in centimeters. And with a centimeter equivalent to a finger breadth, and that's U minus 2, and an example that would indicate a fundal height of 2 centimeters below the umbilicus, which is appropriate for a few days after birth. Okay, you always want to make sure you ask for permission to assess their pad. You don't want to just do a fundal check and just be grabbing all over the patient. Always make sure you need consent to do those things. Alright, so an increase in lochia during the exam is not uncommon. And it's useful for the nurse to observe if the heavy discharge has occurred over time or if it's due to the exam. The nurse should determine the amount of lochia over the course of the hour. Pad being saturated over the course of an hour will be considered heavy flow. Alright, so you got that scant, light, moderate, and heavy. So you got a example here of what that may look like. Alright, clots are a normal part of lochia rubra, if they're small. Clots that are larger than a small in conjunction with heavy lochia are more concerning. Larger clots may prevent the uterus from contracting down adequately, which can cause postpartum hemorrhage. So, this right here appears to be a clot. That's more of a tissue that you may see in a person. When you do the assessment, what you would do is make sure that if you take a clot, you won't see if it dissolves in water. The placental tissue will not dissolve. So as you're palpating that or touching that, you will notice that it's not dissolving. You will just notify the provider. you can have trauma to the perineum as a result of stretching during the labor process, lacerations and episiotomy, varicosities, typically resolve quickly after birth, and we have the rectal varicosities that are like hemorrhoids, they take longer to resolve. Edema, ecchymosis, and discomfort of the perineum is common, so yeah, pain management is a big thing. It's typically ibuprofen, Tylenol. In extreme cases, they'll do opioids like oxycodone. Worsening pain and discomfort is something you want to report to the provider. When you're doing an assessment, so once you've done that photo assessment, you also want to assess the perineum. The best way to do that is to have the patient lie on their side. If it's optimal in that scenario, you want to note any redness, any edema, ecchymosis, any discharge, and an approximation of the wound edges. And that just means that if they had a repair, you want to make sure that wound is lined up together and not open in certain areas. If it is, then you would want to make sure the provider knows.
What's the third word?
That is bruising. And so the nurse should always wear gloves. Like I said, put them on their side. Make sure you always provide privacy. A lot of times in the postpartum room, there's a lot of family in there. Sometimes just check with the patient, ask them what they prefer. If they want people to leave for the assessment, pull the curtain, make sure there's good lighting. A lot of times they don't want you to turn the bright light on, just make sure, I mean, you could do this extreme and use a flashlight, or you could just turn on the overhead light. It should be fine. And then some mild to moderate edema and ecchymosis are expected. Alright, episiotomies and lacerations, signs of infection that you would see would be persistent redness. So if you go in at the beginning of your shift at 7 and you see redness, and then you go back to the end of your shift and it's still there, you just want to make sure you're just making note of that so that the oncoming shift, everybody can kind of see what the trends are for what the laceration or the episiotomy looks like. So purulent discharge and worsening pain are the three things that would be signs of infection. The initial healing takes about 2 to 3 weeks. So you got, so this is an example of an infected tissue right here. So you see you have a swollen here and that, and that's not bulging out in that white discharge there. And then I put this picture here just to give you a visual of what the tears look like. So you see the first degree, the 4th degree. There's some other terms that they use for different, like A and B, but that's usually, the providers usually get that detail. But for nursing purposes, it's okay to just refer to it as 1st degree, 2nd degree, 3rd degree, or 4th degree. 4th degree always goes all the way through the rectal area. And the 3rd and 4th degree people typically have to get some type of female pelvic floor therapy so they don't have future issues with voiding and happy bowel movements and that kind of, those kind of issues. Like I said, Tylenol and ibuprofen are commonly used for pain management. Ice packs are first-line interventions. Topical anesthetics like Dermoplast, which is that spray that helps numb the area and soothe it. You can, if they've had a really bad laceration or episiotomy, which they don't really do those that commonly anymore, you could recommend that they lie on their side to release some of that pressure. Using a peri bottle after voiding or having a bowel movement can help with them not having to wipe in that area and keeping it clean. Sitz baths, with hazel pads, and like I said, the Dermoplast will help relieve pain and itching and even the hemorrhoids. It will provide some relief for that. Stool softeners are really important to educate your patient on during the postpartum period, because a lot of them think, oh, I don't need that. But if you give them that education and let them know that to prevent further damage to their lacerations, having a stool softener is gonna help them so they don't re-tear anything and have to end up back, in the OR or somewhere else. These are physiological changes in the cervix, the vagina, and pelvic muscles. When I send out the slides, this same information is in your book, you can just read over that in detail. And this is just as far as nursing care goes, this is basically saying that you can't really examine the cervix as as a nurse provider can with a speculum. But just discuss different things that they can do to strengthen that area, which would be like people exercises, and just maybe recommending pelvic floor therapy. With the breast changes, so you'll see the colostrum, which is the first thing that comes in that's produced when women after they are delivered, get ready to breastfeed. So that colostrum is rich in nutrients and antibodies, and it's in the second trimester of pregnancy. Colostrum production continues in the early postpartum period, and then it turns into milk. That's usually around 2 to 5 days, and that occurs at a higher volume. If they experience, some people don't experience it at all, but if they do experience that primary engorgement, it's due to swelling of the breast tissue and filling of the ducts with milk. It has more things in it, like the carbohydrates and the protein, than the colostrum, which is why it causes that engorgement. With the engorgement, they may develop a low-grade fever, and also with the engorgement, it will flatten the nipples because, as you can see on the left side, and this may look different on a darker skin patient, but typically they're real full. Sometimes they have like a shiny appearance, and it's very painful for the patient. But it flattens the nipples, and it makes it hard for the babies to latch. So a lot of times they have to either hand express or hand pump so that they can get the baby to latch. All right, so I just talked about that expressing the milk with the pump to provide relief and allow for latching. So when you're doing your assessment as part of that bubble mnemonic, you always want to check or ask about bruising, blood blisters, and tapping, which is kind of common in those first few weeks. And just help them just educate your patient on different ways that they can relieve those symptoms. If they're not planning to breastfeed, they need to avoid nipple stimulation, wear a supportive bra. When they take a shower, face the other way, don't let warm water run down the front because that will stimulate the milk flow. Ice packs may provide them some relief for those who don't want to breastfeed, but they need to be careful with how long they leave the ice on there. And heat should be discouraged because it's just going to further stimulate milk production. So with the blood volume and cardiac function, the cardiovascular system, the most overt change is a dramatic drop in the circulating blood volume after delivery. So in pregnancy, the blood volume increases up to 45%. And the typical blood loss for vaginal birth is between 200 and 500, and for cesarean, 500 to 1,000. Remaining excess blood resolves over the first few postpartum days by a combination of increased diuresis and diaphoresis. I'm just trying to point out what's really important. Okay, so within an hour after birth, the heart rate is expected to decrease. Cardiac output and stroke volume remain high, although slightly lower than immediately after the birth. ABP remains unchanged. And then the cardiac output will gradually decrease over time and return to about the pre-pregnancy output around 3 months postpartum. So nursing care, when it comes to the cardiovascular system, that would be, you want to make sure you're reviewing their vital signs. So not only taking them, but actually looking at them and critically thinking about your patient and presenting what their baseline was. And if you need to report any of your findings. The heart rate is typically elevated for the first hour, and then it decreases A rapid pulse rate is concerning for hemorrhage, but it could also include or indicate pain and anxiety as well. So just combining your assessment findings and just reporting those and then going from there. Low BP reading is a late sign of hemorrhage. If your blood pressure readings are 140 or 90 or greater on 2 occasions, at least 6 hours apart, and that parameter is usually specific to where you're working. It's a concern for continuing preeclampsia or the postpartum onset of preeclampsia. Preeclampsia patients can be at risk for postpartum preeclampsia for up to 42 days after they have a baby, so about 6 weeks. Many patients experience orthostatic hypotension in the first few postpartum days. I have a story about that. I had a patient one time who just delivered. I was a baby, I wasn't nursing, and transferred her from the bed to the wheelchair, and she had been postpartum for about 2 hours, so I didn't even consider it too late. When I stood her up, she just completely lost all of her strength and just fell right in my arms when we were transferred. So she was experiencing some orthostatic hypotension. So just keep it when you're transferring them like that recently after delivery, just be sure to have them sit up, dangle a little bit, and get their affairs together before they transfer. The nurse should encourage, like I said, encourage the patient to sit up slowly. So the biggest thing we're hearing for the blood composition changes would be there's an increased risk for increased clotting risk that continues into the postpartum period. This thrombus formation can need to be a concern for up to 6 weeks postpartum, and is exacerbated by immobility and the tissue damage that occurs in labor and delivery. That's why it's important for them to ambulate, early ambulation. So you should encourage your patient to ambulate early, encourage them to ambulate frequently, evaluate their needs at every assessment for signs of clotting, which would be tenderness, the warmth, the unilateral swelling, all of those signs and symptoms. Patients who can't ambulate, like your cesarean patients who come down who are still on bed rest, that would be your SCDs, your compression devices, and then possibly performing gentle exercises in bed before they actually ambulate. There's a home and sign test that, depending on where you work, whether it's okay to perform the home and sign. I know there's been some new research on whether or not you should actually do the home and sign because of the dislodging of the clot. But I'm not sure how what your.
I don't think they actually do it.
Okay.
Yeah.
Alright. And then it's mostly because you can dislodge the clot and it's a low sensitivity, because even if they do have a positive home and sign, they still have to have further testing confirmed with DBT. Alright, and the immune system, so the biggest thing for this would be patients who are Rh negative. They require specific follow-up postpartum. If the infant is Rh negative, which they test the cord blood after delivery, no further action is necessary. But if the infant is Rh positive, then they will need to have an injection within that first 72 hours, which is called Rogaine. Yes.
How does that work if, so you have your first pregnancy and then the second pregnancy comes around and the mother's Rh negative, you get the first Rogaine injection at like 28 weeks, don't you?
Mm-hmm.
It's 28 weeks,
So
but
you still get
Rogaine
that?
is gonna be on test 3, so you won't have any questions related to Rogaine. Just in case, but it is 28 weeks. Yeah, I just didn't want you to get involved with Rogaine right now.
Did that answer your question, or?
Would you still get that 28-week injection even not knowing the baby's Rh factor yet?
Yeah, initially, if mom is Rh negative, okay, she's gonna get that Rogaine shot at 28 weeks. And then they have to, if we don't actually know, like mom's blood type, I don't know whether y'all notice on deliveries that you have to get cord blood on moms that's O positive and negative. because you don't really know what the baby blood type is. Now, we know daddy is O positive, then the baby is gonna be O positive. So definitely she would get that RhoGAM again within that 72 hours. But we will discuss more about that with test 3.
Okay, and then there's the rubella. If the patient is rubella non-immune, they will administer that. They don't administer it during pregnancy because it's contraindicated, but they can receive that after delivery. And that's just to prevent them, to protect them and baby before baby gets their first vaccine for that at 12 months. All right, and you know that any temperature above 100.4 is suspicion for infection, and we notify the provider. And you should always evaluate your temperature with your other vital signs. And these are the hormone changes that you will see during the postpartum period. The biggest one is going to be the prolactin, because that is what's going to that's going to stimulate breast milk production, and also inhibits menses and ovulation. Breastfeeding and nipple stimulation obviously enhances that prolactin release. And patients who are not lactating and do not have sustained increased levels of prolactin, their first menses is usually about 4 weeks, although it will take a few cycles to ovulate. For people who are lactating, the return of their menses is unpredictable. And so according to the World Health Organization, if they're fully breastfeeding around the clock, if their menses hasn't returned and the infant is under 6 months, a new pregnancy, even without contraception, is unlikely, but that's not 100%. So we tell people to still protect themselves if they are not going to get pregnant. So that's where the nurse would discuss contraception options with the patient. A lot of them don't know their options, so just bring it up when you're caring for the patient. Have you thought about it? Sometimes they may be sensitive to talking about contraception, like they feel you may be trying to push it on them. Just approach it in a way that is, you're just trying to help them understand what their options are. And when you have patients who are breastfeeding, encourage them to feed infant frequently, and that can help them establish a good milk supply by increasing that prolactin hormone. Respiratory system, biggest thing is that patients are at risk for pulmonary embolism. So when you're assessing your patient, just make sure they're not having any difficulty breathing, shortness of breath, chest pain, those kind of things. So you want to evaluate that respiratory rate and listen to their breath sounds. Because if they do have a PD, you're going to hear some adverse, lung sounds. And the nurse should encourage the patient to inform the nurse or any other healthcare provider if they experience any sudden shortness of breath or chest pain. And with the PE, I have a story about that too. I did a postpartum home visit on a patient. When I called her, she wanted to cancel the visit, but over the phone she sounded very short of breath. It was like she couldn't hardly get a word out. So I asked her, I said, I can still come. You sound like you might need, somebody to come check on you. So she agreed. And when I walked in, she was sitting in a chair, labored, breathing. She couldn't hardly talk. When I listened to her, her lungs were, you could just hear all of the crackles and the fluid in her lungs. So she, anyway, needs to say she had to go immediately out. She was admitted to, I think she was in NICU for about a week. But she's fine today, but when somebody has a PE, their symptoms are pretty apparent when you walk in. Let's see, the urinary system, the biggest thing, you want to make sure they're voiding within that first 6 hours or whatever your facility policy is. The extension of the bladder can lead to displacement of the uterus, which may cause urinary acne and bleeding. Retention of the urine may lead to an infection that causes inflammation of the urinary bladder, causes cystitis. And then you've got your symptoms of cystitis, which are pain with voiding, bleeding, pregnancy, and so on. So early in the postpartum period, you wanna instruct the patient to avoid a urine collection device. Just make sure they, like it's a name pad, is what they used to call it. If you put that in there, and that way you can assess the amount that they're avoiding. So you wanna make sure they don't have any of that urinary retention. They may find, some patients may find it easier if you're not actually in the bathroom with them. So maybe turn the water on for them so they can get that stream going. Or they can use the peri bottle with warm water and put it over their perineum, and that may stimulate them to void. If the patient has not voided spontaneously within 12 hours, they may need to be catheterized. And voiding issues related to edema should resolve about 24 hours after birth. The GI system, the progesterone reduces peristalsis of the bowel, and it can still cause the slow stool transit through the GI tract. So you just want to make sure you're educating them on that, the stool softeners and their adequate hydration, high fiber diet. We talked about the stool softeners, routine assessments, making sure you ask if they're passing gas. That way, if they haven't necessarily had a bowel movement, you know that things are moving like as they should if they're passing gas. That's a positive sign. Listen to their bowel sounds. Lack of bowel sounds is indicates of illness. And that's something you want to report if you're not hearing bowel sounds. And then obviously they're going to be hungry and thirsty after delivery. For the musculoskeletal system, this is something you can look at on your own when you review the slides. The neurological system, patients that have had that epidural or spinal, they should have a full return of sensation a few hours after they had their last dose from anesthesia. Rarely there can be patients can experience a very painful headache because of the leakage of cerebrospinal fluid, and the anesthesia provider should be notified for that because they may have to do some interventions on their end to help with that headache. You may hear some people refer to it as a blood patch, is what they usually do. It's a procedure they have to come in for and get done if they've already been discharged home. Sometimes they can catch that headache before they are discharged and get it done before they leave. If the headache is in conjunction with the BP reading that's over the 140/90, there's concerns with preeclampsia that has continued from the pregnancy or a new onset, and she notified the OB provider. And I know at this point you guys haven't talked much about preeclampsia, so that will be in further lectures. So you should be alert for pain and discomfort with your patient, especially if they've had, like if you get a patient and you know they've had a 3rd or 4th degree, you want to really make sure that you're staying on top of their pain and assessing it and communicating with them. And so if they receive anesthesia, you know the first time they ambulate, they should always have assistance. And it may be the first 2 times. I think, is it the first 2 times? It just kind of depends on where you were. But you just want to make sure you're with them when they do that first walk to the bathroom. Alright, and so you know that in addition to ibuprofen and Tylenol, there will be receive opioids. And then if your patient is breastfeeding and they've gotten they're taking the oxycodone or any kind of narcotic, you want to make sure that you are assessing the baby and making sure they're not having any symptoms. It's a low risk for that. It's low transfer to the milk, but you still just want to make sure you're assessing and documenting that. So the bonding and attachment, you guys can take time to read over that. You just want to make sure when you're doing those physical assessments, you want to also assess how they're reacting to their baby, if they're holding the baby, if they're attentive, if they're feeding the baby. Sometimes they may tune out or be affected by everything that's going on, and they may need to be encouraged for that. So you always want to make sure you're assessing the room and how everybody's taking care of the baby and how mom is feeling. Same thing with the partners. They go through something called the partner adaptation phases, which would be for you guys to look over. And for nursing care, just know that everybody doesn't instantly fall in love with their newborn. So sometimes it just may take a little bit of time just to get adjusted. And let's see what else I'm putting over here. Always include the partners when you're doing the assessment, asking if they need anything. It's important to assess their needs as well, because they go through changes too, even not physical changes, but just changes of being a new parent or having a new child. For cesarean, for care after cesarean section, they're recovering from having the baby and from a major abdominal surgery, so we have to take that into consideration. They usually stay in the hospital a little bit longer, a day or two longer than a vaginal birth. Full recovery usually takes about 6 weeks. And then there's more risk for complications with cesarean delivery. And then there's the chart. This is in your textbook as well. Okay. And with postpartum care, let's see, they usually go to a postpartum PACU area to be recovered before they go to postpartum. It's usually one-on-one care. They have more frequent, they have the same frequency of vital signs, sometimes more depending on what anesthesia look like. And they get other things for pain that are a little bit stronger, morphine, sometimes fentanyl. So you just have to be aware of those, what those side effects can be when you give those stronger opioids. You still are gonna do the photo checks. You're still going to give the oxytocin. Because they've had a major abdominal surgery, so they're also at an increased risk for an illness. And then, like I said earlier, flatus is generally considered evidence of functioning bowel. They typically have a Foley catheter that's placed that will be there throughout the postpartum period up to about 12 hours, I believe, depending on where you were. And sometimes you have to address the patient's feelings surrounding the cesarean section, because a lot of times it happens in an emergency situation and the patient may have had an expectation of their birth that was a vaginal delivery, and they have to be able to cope with that. So just addressing the elephant in the room, just being able to comfort them and let them express their feelings around that. So this is just further assessment information for a cesarean patient, cesarean section patient. So sometimes a closure is either with sutures or staples. And if they get staples, they do have to come back and have those removed. And that's based off of the provider on what they use to close the incision, C-section. Alright, so with discharge planning, we know that starts as soon as the family is admitted to postpartum. And a lot of times patients can be discharged up to 48 hours after contemplated birth. Sometimes early discharge is granted if the OB provider and the pediatrician agree. Sometimes they will be discharged at the 24-hour mark. And the infant care and feeding, you want to make sure you get information together so that you can be discharged, you can know infant care, feeding, patient discomfort, patient nutrition, and activity, contraception, and all those topics. The nurse should be aware of and communicate to the patient clinical signs of common postpartum complications and communicate need for further assistance. So the chart is also in your textbook. So just different, you want to make sure they know these, because sometimes people will just feel like it's normal and they think it's something that is just normal for after delivery. So just let them know that they should call their provider if they experience any of those. The nurse should also provide discharge instructions concerning anticipated postpartum physical changes. Chart, having that, breast engorgement, diaphoresis, diuresis, weight loss, and uterine involution and lochia. So postpartum, period is a lot of patient education, especially if it's their first baby. And even if it's not their first baby, you learn something different after each pregnancy. So just making sure your patient is well prepared to go home. And that is the end of my presentation.
Good. Let's give her a hand. See if I can get a